Hello. Thank you. Assalamu alaikum. Good evening. Surgery Casualty Block 2. I am today's presenter, Dr. Mohammad Sabi Ahmed, Honorary Medical Officer, Surgery Casualty Block 2, Dhaka Medical College Hospital. Now I would like to begin my today's presentation on shock in trauma patient. First, what is shock? Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration. Pathophysiology of shock, there are cellular level and microvascular level. In cellular level, when tissue perfusion is reduced, metabolism convert into anaerobic metabolism, thus production of lactic acid and systemic metabolic acidosis occur in our body. At the same time, intercellular lysosomes release autodigestive enzymes, which causes cell lysis. Microvascular pathophysiology, when tissue ischemia progress, activation of immune and coagulation system. Hypoxia and acidosis activate the complement and primary neutrophils. Thus, generation of oxygen-free radicals and cytokine release. Injury to the capillary endothelium leads to loss of its integrity and the capillary endothelium becomes leaky. The other pathophysiology includes cardiovascular system, respiratory system, renal system, endocrine, and the next one is ischemia reperfusion syndrome. What is ischemia reperfusion syndrome? When tissue hyperperfusion persists for a long time, hypoxia causes the activation of cellular and humoral elements, that is complement, neutrophil, microvascular thrombi. When normal circulation is restored, these are flushed back into circulation and causes further endothelial injury and organ damage like acute lung injury, acute renal injury, multiple organ failure, which leads to death of the patient. Then types of shock. There are 5 types of shock. Hypovolemic shock, which is hemorrhagic or non-hemorrhagic cause. Non-hemorrhagic cause may include decrease intake of fluid, increase fluid from the body like diarrhea, vomiting, and the third spacing of the fluid, that is moves of the intravascular fluid into the interstitial space, which occur in bowel obstruction and pancreatitis. The second one is cardiogenic shock, which is due to the primary failure of the heart to pump out the blood to the tissue, and the causes are myocardial infarction, cardiac dysarrhythmia, valvular heart disease. That's all. And the third one is obstructive shock, in which decreased preload by primary mechanical obstruction to the cardiac filling, and it is caused by cardiac tamponade, tension pneumothorax, and major pulmonary embolus or air emboli. The fourth one is which includes septic shock, anaphylactic shock, and neurogenic shock. The fifth one is endocrine shock, which may present with the combination of hypovolemic shock, obstructive shock, and distributive shock. And it is caused by hypo and hyperparathyroidism as well as the adrenal insufficiency. Now, stages of shock. There are 4 stages of shock: initial stage, compensatory stage, progressive stage, and irreversible stage. The initial stage. Initially, our body compensates with the onset of the shock. No changes are noted clinically. Changes are beginning to occur on the cellular level. Then compensatory stage. In compensatory stage, fluid shift from the interstitial space to the intravascular space, and the sympathetic nervous system by the release of epinephrine and norepinephrine At the same time, kidney release renin into the blood and formation of angiotensin and release of aldosterone and antidiuretic hormone. Here is the diagram, how our body compensate the shock primarily. When cardiac output decrease, renin is secreted by the kidney and it goes to the liver, and angiotensinogen convert into angiotensin 1, and angiotensin 1 is converted by angiotensin converting enzyme in the lung into angiotensinogen 2, and it also stimulates the release of aldosterone and antidiuretic hormone from the posterior pituitary, which increase the blood volume by acting on renal tubule. Thus, blood pressure is maintained. On the other hand, sympathetic nervous system is stimulated. Epinephrine and non-epinephrine is released, which caused vasoconstriction and increase the total peripheral resistance. Thus, it increased the blood pressure up to normal level. Now the third stage, progressive stage. In progressive stage, vicious circle of compensation eventually leads to decompensation. Blood pressure starts to fall and systemic blood pressure below 80 is considered danger signal. In this case, we found in patient tachycardia, tachypnea, decreased urinary output, and decreased body temperature in the form of cold, pale, clammy skin. Now, irreversible stage. In irreversible stage, body attempts at compensation have failed and sludging of blood, thus thrombosis of small vessels occur, tissue hypoxia and anoxia occur, which leads to lactic acid accumulation, contributes to cell death. Now, severity of shock. How can we determine the severity of shock? Here in the table, we say there are four types severity of shock, that is compensated shock, mild shock, moderate shock, and severe shock. In urinary output is normal in compensated and mild shock. It is noted that in mild shock, in urinary output and blood pressure may be normal. So how can we differentiate clinically in the patient with mild shock? In this case, we should measure the respiratory rate and pulse, which are increased in mild shock. Now, shock in trauma patient. Shock is a common and frequently treatable cause of death, and it is the second most common cause of death from trauma. We should follow the ATLS guideline, that is advanced trauma life support. When a patient arrives in our casualty department, we should go for primary survey that constitutes of ABCDE, C for exsanguinating external hemorrhage from massive arterial bleeding needs to be controlled even before the airway is managed. A goes for airway with cervical spine control. We should, if any frothy discharge, then we should clean it by any means or by using the Saka machine, and we also fix the cervical spine if it is necessary. The third, then we look for breathing and ventilation assessment and ensure the adequate oxygenation for the patient. The fourth one is the most important, circulation and hemorrhage. We must control the perfusion. D4 is done by the Glasgow Coma scale, and last one is with environmental control, undress the patient and search everywhere for possible injury while preventing hypothermia. আমার কথা কি শোনা যাচ্ছে?
জি, ক্লিয়ারলি আসছে।
জি, শোনা যাচ্ছে।
জি, থ্যাংক ইউ। Now, in this picture, we are seeing the a doctor from our casualty department receiving a patient with proper safety measure in this COVID pandemic, measuring the blood pressure of the patient, and the another picture showing our one of our nurse inserting cannula of the right hand of the patient. Okay, how can we understand is the patient in shock or not? Blood pressure is not reliable. We saw in the previous slide, BP blood pressure falls when 30% blood volume is lost. So we must look for pulse rate, respiratory rate, urinary output, and conscious level of the patient. Point to be noted that any injured patient who is cool and has tachycardia is considered to be in shock until proven otherwise. So, whether it is hemorrhagic shock or not, try to find the source of bleeding. The source may be from chest, abdomen, pelvis, and extremities. We also look for any external bleeding. What to do? First, we resuscitate the patient, then we go for focused assessment. So, then we may send the patient for X and whole body CT scan, and that is the gold standard investigation for trauma patient. But we must resuscitate the patient first. Now, hemorrhagic shock. Advanced Trauma Life Support Manual describes 4 classes of shock to emphasize the early signs of the shock state. The adult human has approximately 5 liters of blood, that is 70 ml per kg in children in adults, and 80 ml per kg in units. Volume replacement is determined by patient's response to initial therapy. Hemorrhage control and balanced fluid resuscitation must be initiated when early sign symptoms of blood loss are apparent or suspected. Bleeding patients need blood, that is blood for blood. Now another 2 pictures is showing in my slide. In the left picture, we're showing the blood is given to the patient, and the right picture also showing the white bore cannula, that is 18G, the green color. Patient is given blood for blood loss. Now, how can we determine the hemorrhage? There are 4 classes. The class 1 hemorrhage. The class 1 hemorrhage is called when blood volume loss up to 15%. And in this case, the heart rate is minimally elevated or normal, and there is no changes in blood pressure, pulse pressure, or rate. Class 1 hemorrhage usually don't require blood. Class 2 hemorrhage, 15 to 30% blood volume loss. It is called class 2 hemorrhage, manifested clinically as tachycardia, that is heart rate is 100 to 120 beats per minute, and tachypnea, that is respiratory rate 20 to 24 breaths per minute. Decreased pulse pressure, although systolic blood pressure changes minimally if at all. Skin may be cool and clammy, and capillary refill may be delayed. Management of class 2 hemorrhage, that is most of the patient stabilized with crystalloid, few may require blood. The third one is class 3 hemorrhage, 30 to 40% blood volume loss, resulting in a significant drop in blood pressure and changes in mental status. In patient, we may found in systolic blood pressure less than 90 millimeter of mercury, drop in blood pressure greater than 20 to 30% of the measurement at the presentation in cause of concern. When heart rate is more than and equal 120 beats per minute and it is 3D, and the respiratory rate are markedly elevated, while urine output is diminished, capillary refill is delayed. Management, stop bleeding and blood transfusion. Now, class 4 hemorrhage, when more than 40% blood volume is lost, it is called class 4 hemorrhage, and it is a life-threatening condition. Patients are hypotensive, pulse pressure is narrowed, urine output is minimal, or patient may be anuric. The skin is cold and pale, and the capillary refill is delayed. And management of class 4 hemorrhage is rapid fluid transfusion and surgical intervention depending on initial fluid response. So the fractures and soft tissue injuries, the calculation of blood loss at the fracture site, if tibia or humerus are fractured, then 75 ml blood, approximately 750 ml blood is lost.
750.
Ji, sir. 750 ml blood is lost, and if the femur is fractured, then it's the double, that is 1500 ml blood is lost, and the retroperitoneal organ is liters of blood is approximately lost. At the same time, edema in the injured soft tissue, released of inflammatory mediators, depletes the intravascular volume, that is fluid moves from the intravascular space to the interstitial space because the capillary endothelium becomes leaky. So how to use it? In previous slide, how to use it in our clinical practice. So here is the example. If a 70 kg patient comes to us with clinically femur fracture, estimated blood loss, classification of shock and fluids, then estimated blood volume of this patient is as we see in the previous slide, that adult human contains 70 ml blood per kg. So he is 70 kg weight. So 17 to 70, that is 4,900 ml blood in his body. So blood loss in there is femur fracture, that is approximately 1500 ml blood is lost. So percentage of blood loss is 4,900 into 100 divided by 1500, and it is 32.6%. So 30 to 40% blood loss is classified as class 3 hemorrhage. In this case, we should treat the patient with crystalloid and must by the blood products. Now management of shock. First one is resuscitation and then fluid therapy. If there is initial doubt about the cause of shock, it is safer to assume the cause is hypovolemia and begin with fluid resuscitation and then assess the response. Fluid therapy in all cases of shock, regardless of classification, hypovolemia and inadequate preload must be addressed before other therapy is instituted. Types of fluid, the crystalloids, colloids, blood and blood products. Commonly used crystalloids are normal saline, that is 0.9% sodium chloride, Hirschman solution, Ringer's lactate. Colloids are used albumin or other commercially available products. And the third one is blood and blood products, which is most important. Remember, oxygen carrying capacity of crystalloid and colloids are 0. If blood is being lost, the ideal replacement fluid is blood, although crystalloid therapy may be required while awaiting blood products. Now a term, permissive hypotension. The initial aim of resuscitation is to maintain the blood supply to the vital organs like brain, heart, kidneys. For a short time, this can be achieved with a target systolic blood pressure of 70 to 90 millimeter of mercury, and this is called permissive hypotension. Although a higher blood pressure of more than 90 millimeter of mercury should be the target if a heat injury is suspected. Another, remember, excessive intravenous crystalloid or colloid solutions should be avoided because they cause increase coagulopathy and increase the risk of acute respiratory distress syndromes. Then dynamic fluid response. When we initiate or infused 250 to 500 ml of fluid is rapidly given over 5 to 10 minutes, and then we observe the heart rate, blood pressure, and central venous pressure. We can categorize the patients in 3 categories. The first one is responders. The patient is not actively losing blood, but require filling to a normal volume status. Some patients are transient responders. They have moderate ongoing fluid loss, and some are non-responders that usually through persistent uncontrolled hemorrhage. Now, how can we monitor the patients in shock? Minimum, we should do ECG, pulse oximetry, which provide us the oxygen saturation level and blood pressure, urinary output, and the additional modalities are central venous pressure, invasive blood pressure, cardiac output, base deficit, and serum lactate. Now, end point of resuscitation. It is said that it is much easier to know when to start resuscitation than when to stop. Traditionally, patients have been resuscitated until they have a normal blood pressure, pulse, and urine output. A patient, therefore, may be resuscitated to restore central perfusion to the brain, lungs, and kidneys, and yet continue to underperfuse gut and muscle beds. This stage of normal science and continued underperfusion is termed as occult hypoperfusion. So when we stop the resuscitation algorithms directed at correcting global perfusion endpoints, that is base deficit, serum lactate, and mixed venous oxygen saturation. This is already said in previous slide. The further investigation after resuscitate the patient, when the patient is hemodynamically stable, the patient may be sent for further investigation like X-ray, ultrasonography, and whole body CT scan. Then, what are the consequences if the patient in shock is untreated, remain untreated? The patient may go to the unresuscitated shock, and the multiple organ failure may occur in lungs, the acute respiratory distress syndromes, kidney, acute renal insufficiency, coagulopathy, and cardiovascular failure may occur. Thank you all for patience hearing.